one of the points that I think that was made, well, definitely was made before I was on. I think with Jen made the comment about Hep C testing, which I think is extraordinarily important and something that we have to look at how we're going to screen people for Hep C, and this is really important as we go through. And so I've looked at some kind of guidelines for this, and and so there's a combination really for the CDC and the Australian consensus kind of guidelines for basically how we can test people for Hep C, how we can screen people for Hep C, because I think this is important. So obviously we know with pregnant women, there is universal hepatitis C screening, and like hepatitis B, it's almost done in everybody. It's fantastic. It's one of the things that often we find new patients, and we find new patients because of the fact that they were screened in pregnancy, and it really is useful. And I think it's one of the great things that happen. But let's look at other groups. So I suppose it's a bit small, but these are important groups, and I think we can talk about them. These are just suggestions. I mean, we're not mandating any of these yet, but I think these are suggestions, and maybe we have to think about screening in a bigger environment like this. And I think we have to think about whether that's useful or not. And the prevalence is different in these groups, but I think that they're important people that potentially have hepatitis C. So obviously, persons with HIV and Hep B, we do it as a rule pretty much. When we see someone with hepatitis B, we always also test for hepatitis C, especially in the groups that we're talking about. HIV similarly, it's not uncommon for us, but I think as a rule, we should hopefully make that as a thing that we do commonly, I think. The other groups are a little bit more controversial perhaps, but something we have to talk about. Tattoos and body piercing is a big group. This is predominantly by the CDC, and I was just noticing how many people are tattooed recently, or just as you walk around, and I wonder how much increasing that increased amount of testing would that be. The good thing is that most tattoo parlors are, of course, very reasonable and very good, and they don't have shared needles and all the other aspects that might lead to hepatitis C. But nevertheless, I think it's something, especially maybe at a certain age group, that we have to think about, maybe in terms of testing. The other group, of course, is pretty obvious, which is the people who have ever injected drugs, and ever is important. One of the things that we commonly see, especially with the hepatitis C patients, is not that they're injecting now. That is an important group, but they had injected previously, and they might have had just one experience. It's always one experience, of course. That's what they tell you when you talk to them. So, oh yes, I injected once and I got Hep C, but maybe that's true. But it is a common thing that I hear. And of course, people that share needles, syringes, or other drug preparation equipment. And once again, I said from now and also previously, which is a much harder group, because now they don't, it's past. They're past in their minds. They don't even think of it as a real aspect of their life, just a bit of playing around when they were young, in their 20s or 16s or 15, that sort of group. So I think it is important to look at that. Also, people with selected medical conditions, particularly, this is again America, but we might want to think about some of this. It's not that important here because people that have renal failure that are on dialysis are tested, but nevertheless, it is something that we should think about as a group that might be involved, especially in the older age group. And of course, the same thing applies to recipients of organ transplants, etc., and receive clotting blood really early on. And we know that's a major problem. The other thing is needle sticks and people who've been injected with that. We all, most of those people get tested. I think it's hard to really tell because I guess people get a one stick from some on the beach somewhere or something like that. I don't know whether they all come into the emergency room and get tested, or to see the doctor get tested. But there's obviously a group that's important. Obviously, children born to mothers with HCV infection and sexual partners of HCV infected individuals is our major groups, and we should always test them, I think. The other group is more controversial, but perhaps more relevant. One of the things that we heard earlier about where our HCV patients come from and things like that. The interesting thing is that there are high prevalence areas of HCV, and places like Egypt Pakistan, Afghanistan, Mediterranean, and Eastern Europe, Africa and Asia as well. So I think these are different areas, but things to think about, I think, in terms of this group of patients. And then maybe there's also a room for periodic testing in some patients with ongoing risk factors. So these are people that are still using drugs, obviously, so they be repeatedly probably need to be retested regularly, and it's something that I guess we don't do very well, but it's something that we probably should try to initiate, and probably mainly at the GP level in terms of testing this group. And again, forget the dialysis puppet. I think this general last rule is important, which is anyone that requests hepatitis C testing, even though they don't tell you the risk for it. And the reason is that people don't always tell you everything about the history that they may find embarrassing or difficult. And so I think it is really important that we look at that and just offer the testing in that regard if they want them. Thanks very much. So I want to talk a little about our project to eliminate HCV in Mildura. It's something that we're very excited about, and I think we're getting very far in this. Now, I'm sorry, but I didn't have Yasmin's picture up. It's not fair, I know, but yeah, but you know, unfortunately, we didn't have Yasmin's picture. Otherwise, she is, as Joe says, the most important person that we have in the hepatitis field here in Mildura, and she's absolutely essential. And we were even talking about patients a few minutes ago, because it's just something we have very good communication, and we talk about it all the time. But we started a service, I think, a number of years ago, and Joe mentioned this, and it's about 10 years ago, and it was initially funded by one of these rural workforce agencies, and then some of the funding was terminated. But anyway, that's just by the way. We currently are located at Sunraysia, and Yasmin's a very important part of that as well. Thank you. So we do come down here pretty regularly, actually, and we used to make face-to-face visits about 4 times a year. It's been a bit less now because of COVID and things like that, and we have more and more telehealth visits now. At least we probably do a telehealth visit every month now, so it's quite a lot. So there's no problem. I should mention all our consultations are bulk billed, so that I think is kind of important for people when you might want to refer to us. And as you know, we're involved with medical education and support as well, and also support regarding the vaccines and COVID and etc. And lots of conversations about infectious diseases and also sexually transmitted diseases. But I won't talk about that today. Thanks. So I'm not going to really go over this. I think Jen's already covered most of the stuff, but the hepatitis C prevalence in Australia is well known. Go to the next one. Next, and we're just obviously really interested in up here where we are in terms of Mildura, the Mildura region. Next slide. Yeah, next slide. I won't go through all this. This is a little bit about the acute natural history of the natural history of hepatitis C, and so. Like Joe was talking about hepatitis B, this is a different virus, hepatitis C, that has a 20% spontaneous clearance, but most people go on to more chronic hepatitis C, and that's why it's completely different to hepatitis B. But it really had a problem with cirrhosis and again, HCC in the long term. And the same complications that Joe were talking about in terms of decompensation and liver failure occur with hepatitis C as they do with hepatitis B. The interesting thing is, in this case, is like Joe was talking about with the different viral testing here, it's a little simpler, but a little more complicated in a way, because a lot of people get the HCV antibody test, which is the first screening test that we all do for hepatitis C. Now, that's fine. That doesn't mean that necessarily you have still active hepatitis C, and we do a hepatitis C RNA that will prove the positivity. It's the other thing that's important is when we treat patients, which in this case, unlike in hepatitis B, leads to a complete cure, the hepatitis C antibodies often remains positive. And so you have to tell your patients at the end of the treatment, yes, there's no point just doing HCV antibody anymore, because in fact, that's still positive. And that's an important also consideration for the blood bank too. If people that were transfusing, we're giving blood to the blood bank, unfortunately, they still won't be able to give blood to the blood bank after this because they're tested very quickly for hepatitis C, and that's not a condition to give blood anymore. And of course, as was mentioned earlier, hepatitis C, definitely leads to HCC, and obviously one of the big reasons we're worried about it. It is important to mention again that that just because we treat and cure people with hepatitis C doesn't mean that we can stop screening them for HCC, because it is a big problem and it does continue. And whatever the events were that caused the hepatitis C occurred a long time ago, usually probably when the infection occurred. Next slide. But this is the amazing thing, and I think what we all hope for with hepatitis B sometime in the future. But we've I've been really lucky in my life to start off with a disease that wasn't even called hepatitis C. It's called non-A, non-B hepatitis and all these other things. And now we've got a cure for it. And it's fantastic. Really a simple single drug now, taken for a period of 12 weeks in most cases. There's a little bit of variation, but and there are shorter courses, but they give incredible percentages of cure. I mean, 98, 99% cure. This is just, it's amazing. And I've had so many patients, if you even forget to take a tablet or two, they still get cured. So it's extraordinarily sensitive to this, and it works really, really well. And so it is fantastic. And I think the problem partly was the earlier treatments for hepatitis C were all related to pegylated interferon, which is a drug. And I don't want to say it's a bad drug, even though, because I did treat a lot of people with pegylated interferon, and it did certainly work in some patients, but it certainly had a lot more side effects, because it's a bit like having the flu, because in fact, when you have the flu, you have a lot of interferon produced, and that's exactly how you feel, like you have really severe flu for a really long time. And remember, the treatment is much more prolonged. So it's like having the flu for months. So it's really horrible in that regard, but nevertheless, it's much better to have the tablet. So a lot of people couldn't have also that treatment, especially people with mental illness. So people with mental illness, we couldn't give them pegylated interferon because of the interactions and problems with the treatment. And now they can have the tablet. So they were refused it then. So they engaged some sort of hepatitis service at that time, but then they couldn't have it, so they'd just forgotten about it. So there's a group like that have had, previously have wanted to have some hep C treatment, but couldn't have it. And so that's a big group, I think, that also needs to be treated. Mental illness particularly was one reason we couldn't treat. So again, they're very easy to treat, this group. Yep. Yeah, and this is the big thing. It's cure. It's cure. It's absolutely cure. So when they're finished, they're clear. They still need to be, like I said, screened for if they had some damage beforehand in terms of HCC, but otherwise they're cured. The only caveat to that, of course, is they're re-exposed. So if they reuse drugs, or they can certainly get hep C again, and we have a number of patients that have had 2 or 3 times they've had hep C. We try to discourage this, but it doesn't always work that way, as you know, in life. So so we're interested in that group as well, the people that might recur in terms of treatment. But that's the fantastic thing about hep C. And I think we talked about this before. I think Jen did, that basically that overall the Victorian rate is very high for reasonably high for hep C treatment uptake, but in Mildura it's always been low, and it's been something that we wanted to really tackle. So we developed this project to eliminate hep C in Mildura, and you might say, you want to eliminate hep C in this whole community? But that's what we wanted to do. We thought that was really important, because we thought that we have a drug that can cure people. All we have to do is find them, engage them, and treat them, and make sure that they're cured. And we thought that it's kind of important because we could really climb this mountain, hopefully. Next slide. And why is Mildura really a great place for eliminating HCV? I think it is. I think it's one of these places because, first of all, it's got a reasonable sized community. It's a lot of Indigenous people here. There's also a high diversity of these people, of different people, different households with languages. And the prevalence is approximately 1 in 500 individuals. And with a poor treatment intake, I think the big thing is that it's self-contained in many ways. People stay here, and it's actually a group that actually can be completely treated. So we think we could be one of the first cities in the country, really, and I don't know, in the world, to actually completely eliminate Hep C. So we have developed this project together for this reason. And we have involved much of people, and we'll talk about that in a minute. But I think the location and the sort of self-isolation of Mildura might be very useful in this regard. Next slide. So we kind of divided them into 4 things. So identify, so we have to identify these patients. And we were thinking about how we would do this. So we had 2 major approaches that we've taken to this. First of all, we would look at some PHN data. So this is data for the whole of the area. And there we would be able to look at people that are known to be HCV positive, because this is one group. So people, have been picked up somewhere along the line that they're Hep C positive, but nothing was ever done after that. And then we have to then take it back to the practice, get the GP to bring the patient in, and then hopefully in a nurse-led model, basically get the nurse to kind of counsel the patient for taking the blood test, and then look at ways to offer treatment. But that's the big thing. The counseling is very important because we need to discuss treatment, because we don't want refusals there. We want to basically be able to treat these patients, and then to organize a blood test, because you don't know what happened since that time, or we don't even know whether we have real positivity. These are people that are HCV antibody positive, so we won't know whether they really got hepatitis C at all either. So it's important to do that. And then in terms of treatment, well, we don't really mind. We're happy to treat them through Sunraysia, and Yasmin can coordinate that aspect, or we can encourage the GP to do it. It's a pretty straightforward process. We're happy to counsel them, help them. We can support them, and we would do all that, I think, to try to make sure that the treatment occurred. And again, another difficult thing that we've been finding even in our other clinics is follow-up. And it just makes us feel better, maybe. But as I said to you, the success rates are very high. So even if we didn't get the follow-up, we wouldn't be completely depressed, because I think that we would say that most of the people that had been treated would be cured. But nevertheless, for completeness, I think the follow-up is important too. And I mentioned how we're going to implement this, how we talk about the electronic medical records. This is about the electronic medical records in the practices, but also in the PHN database. The other thing is that we would talk about some of that screening stuff I mentioned earlier, and ask the GPs in the area to start screening for that sort of group. And the other group we'd like to talk about screening is the Mildura-based hospital, that people come into emergency, because there's a big group there that when they come in with some of the criteria we talked about there, particularly the IV drug use, you can say, well, this is a worthwhile screening with the patient's permission, and to then basically then follow them up. The big problem is that we've been even doing this in Melbourne, is if you find they're positive in the emergency room or in the hospital, we find that doesn't translate to coming back and having treatment. So obviously, if there's a way, and we're talking about this earlier, is if there's a way to have straight away point of care testing in that group in the hospital, that would be fantastic. In other words, if we could go from the antibody positivity the positive test in the hospital and start treatment there. That would be ideal, because then we don't lose control of this patient. But that is something probably a little bit hard to get to, but that'll be the ideal way, I think, to getting all these things working out and hopefully leading to elimination. The other big group is the Indigenous population. And I think we need to have, we're lucky because we have MDAS here and MDAS, and so it's really important to kind of really get some engagement there in terms of the patients and really look at how we can improve the rapport and improve this system in that regard, because that's a big population that we also want to make sure that we establish and we actually improve on. Hopefully we can use our connections, including some people in the room that in this area to help that and actually improve that, because I think this is something we probably need in all of Australia, but maybe in this community we can use it as an example of how do we do this. So this is the group of people we want to do it, how we do it. And the great thing is that we have been able to engage with the Mildura City Council, as well. Is it City Council or Rural Council? it's the Mildura Council, as well as the key stakeholders, including MDAS, including Centrasia, including the hospital. So these groups have all agreed to come together this. And in fact, together we applied to the Violet Marshman Trust and actually got half the money we need so far, which is 50,000 to do this. And that's already come through now. And then hopefully we'll get the rest of the money sorted out and get the thing started. But so we're well on our way. And the great thing we want is the community engagement. It's fantastic to have Mildura Council on board, because it means the people are part of this. And it's the only way this can work. But maybe with that combination of these things, we can actually get to that point. And I can see this happening. And if you look at the next slide, we kind of project this would take about 2 or 3 years. 2 years, actually, not 3. But the idea being that would take that time to get this going. But that we could probably get this down and eliminate this virus in this community, which is just amazing thing if you ask me, in a couple of years. So that's where we're hoping. So hopefully we'll be able to report back to you in a couple of years and with some success to say that we've done what we wanted to do. That'd be great. That's it, I think. That's nothing. Thanks very much.